Mr. Chairman, time is up.
Okay. Hello everyone. I'm Dr. Zhongxuan Lin from Kaohsiung, Taiwan. Welcome all of you to participate APSC Cloud Forum of Cardiovascular Disease. Today, my co-chair physician is Dr. Gray Watt. Now we were waiting for his online. So welcome all of you to our symposium entitled "No Cholesterol, No Coronary Heart Disease: Facts or Fiction." I think all of you know that dyslipidemia is a very important disease. It's a very important risk factor for cardiovascular disease. Today, we will have 6 speakers. We will participate this symposium and give a different topic discussion, the role of dyslipidemia treatment. Because the first speaker is not online, so I will invite the second speaker, Dr. Ondra Mani Hickory. He is from Nepal. Currently, he is the Executive Director, Shahid Gangalo National Heart Center, and the Associate Professor of Cardiology, National Academy of Medical Science, and the President-elect Cardio Society of Nepal. Today, he will give a talk entitled Treatment Goals of LDL Cholesterol Lowering for Primary Prevention of ASCVD Risk, Different Cardiovascular Risk Category Counts. Professor Ondra Mani Hickory, please.
Can you see my slides, please?
Yes, very clear.
Yeah. So thank you very much for giving me this opportunity. So my topic for today's presentation is treatment goal of LDL cholesterol lowering for primary prevention of ASCVD risks, different CV risk category counts. So we all know that ASCVD is the leading cause of morbidity and mortality worldwide. And we also know that prevention is always better than the cure. So prevention of ASCVD, the most important thing is recognition and management of this risk factor, and the main preventable risk factor for CVD that can be changed or managed are smoking, hypertension, dyslipidemia, diabetes, obesity, poor nutrition, and alcohol consumption. When we talk about the primary prevention, there are two approaches. One is individual based approach with risk prediction model and treating the high risk patient with in our term treating the hypertension, diabetes, dyslipidemia, and other things, and the population based, that is targeting the entire population through government and the public health policy. These are the two options. So we will be focusing on the personal one, the first one, not the community one. So why dyslipidemia is important in prevention of ASCVD? Because dyslipidemia is strongly associated with the pathology of cardiovascular diseases. It is an independent preventable risk factor for coronary disease and leads to the development of atherosclerosis and associated cardiovascular events. And cholesterol play a central role in the pathophysiology of this disease progression, where the cholesterol gradually build up and the chronic inflammation of the arterial wall takes place. Longer an individual is exposed to the elevated blood cholesterol, the higher chance of getting the ASCVD. What is dyslipidemia? Dyslipidemia refers to either lipoprotein production or deficiency, which is a consequence of abnormal lipoprotein metabolism, and this leads to elevated total cholesterol, low LDL, and triglyceride, and there is a decrease in the high density lipoprotein, that is HDL concentration in the blood. So among those cholesterol, the LDL cholesterol has been the most commonly used clinical lipid measures in ASCVD prevention. Multiple evidence from laboratory, epidemiological, and genetic studies indicate that increased circulating LDL causes the escalated deposition of the blood cholesterol in the arterial wall that leads to the vascular inflammation and atherosclerosis. This is the diagram, the one of the famous diagram in how LDL or cholesterol helps in developing the atherosclerotic region or a plaque, and then how a patient develops acute coronary syndrome or how patient develops into chronic coronary syndrome. So what is the importance of LDL lowering for prevention of ASCVD? The Birmingham Heart Study identified the cholesterol as a risk factor associated with CAD in 1961. Since then, growing clinical, epidemiological, and randomized trial evidence has firmly established LDL as a causal and highly modifiable risk factor in development and the pathogenesis of ASCVD. And research study demonstrate that individuals without established coronary artery disease, early initiation of statin therapy to decrease LDL could obtain a similar CV risk as those with untreated low LDL levels. It is clear that maintaining the adequate LDL level early in life is an effective intervention to prevent ASCVD. So, what are the evidence? Data from large RCT shows that achieving low LDL level is associated with a greater ASCVD benefit, and current recommendation for cholesterol management emphasize achieving optimal lipid level for the longest period possible. Lower for longer is better using proven safe therapies. So to address the serious health effect of the dyslipidemia, various countries have developed one guidelines to manage the disease process and provide clinical guidance for appropriate healthcare, especially in specific circumstances. Let's start from this article. So what they say, what they do is they do the risk scoring, and then they decided about the target LDL level and at what level they should be treated. They have this says that it says that even there is a low score, but if the LDL is more than 190, they should be treated with cholesterol lowering drugs. And if the cholesterol in low risk category, if 131 to 190, then they should go for cholesterol lowering doses. So they have a different ideas, and there's more about the use of statin. They have the same thing, just like high intensity statin or moderate intensity statin. They are all similar. And there is one guideline from South Asia Pacific region, from Taiwan. What they did is in primary prevention, they said that diabetes, CKD, and or LDL of more than or equals to 190 milligram per deciliter are categorized at high risk for developing ASCVD. So they said that they should be treated with lipid lowering therapy, and the target of LDL should be less than 100 milligram per deciliter. And apart from these cases, they have classified hypertension as premature family history of CAD, SDL level less than 40 in male and less than 50 in woman, smoking, and metabolic syndrome. If they have more than 2 risk factors, and if the LDL level is more than 115, they should be treated with moderate intensity statin if there is only risk factor. So they have classified in this way, so that the lipid management will be easy in their part of the world. And there is one more from the Washington guideline team. They say that under 40, routine screening is not even recommended unless patient has a major cardiovascular risk factors, so diabetes, hypertension, family history, and smoking. And 40 to 75, non-fasting lipid panel every 5 years minimum. And over the 75 years, routine screening is not recommended. So based upon the risk factor, they have divided in different categories, and they have said that they can start with moderate to high intensity statin, but in age more than 75, it's almost common that it should be used a shared decision making. And if LDL is more than 190, they said that you have to start and continue high intensity statin. And diabetic also, they have the same criteria just like others. And this is a nice guideline from England, and it also classifies primary prevention in different categories, and based upon the categories, they advise for different approaches. So what they have used the QRIX score classification, but they have similar in all those previous guidelines. If the patient had severe hypercholesteremia, they immediately go for higher high intensity statin. This is a guideline from a neighboring country of Nepal. It's known as LI guideline. It's Lipid Association of India to 2023 guideline. They have categorized major ASCVD risk factor, and from those they have features, the high risk features, then risk modifier, and based upon the risk category, they have advised for the therapy. Not only therapy, they have also advised for the treatment targets. And when the treatment target are not met, what need to do? They said that you need to keep on drugs like ezetimibe, bempedoic acid, and also PCSK9. This is how. And in diabetes, they have gone for a target level of LDL level of less than 70, and those patients should be treated with statins. And this is a guideline from Canada. This is known as Peer Simplified Lipid Guideline 2023 update. And what they have done is calculate. They have all. They say that calculate 10 years cardiovascular risk, and if the risk is less than 10, then encourage lifestyle modification only, and consider re-estimate in 5 to 10 years. If it risk is then between 10 to 19, encourage healthy lifestyle, and suggest discussing about the statin, specifically moderate statin, and high risk go for a high intensity statin. And in secondary prevention, they have classified high risk category into a secondary prevention category. This is a Chinese guideline, which was published in 2023. They have almost similar. Just what they have done is those who meet any of the following criteria directly classified as high risk without the need of 10 years ASCVD risk classification. Those cases are LDL more than 4.9 millimole per liter, or total cholesterol more than 7.2 millimole per liter, diabetic patient of age more than or equals to 40 years, and CKD 3 to 5. And for all others, we have to look for a 10 years risk. And they have developed a small simplified version with the help of blood pressure, non-SDL level, and SDL level, BMI, and smoking. And what they have done is they have not given any specific target, but what they have done is they go for moderate intensity or high intensity, or adding some drugs. And also they have given, sorry, I missed something, that they have given the target for medium and high risk. The LDL should be less than 22.6, very high risk less than 1.8, and ultra high risk less than 1.4, and low risk you can go for less than 3.4. That is the target. And also Japanese JSA also had a guideline. They have published in 2017. They have made it very easy. So if the patient had diabetes, CKD, non-cardiogenic cerebral infarction, and peripheral vascular artery disease, then they classified it as high risk. And then if they have a score called SWEET-I score, based upon that score, they classify into low risk, moderate risk, and high risk. And then what they have done is if they are high risk, then LDL target should be less than 120, and if moderate risk less than 140, low risk less than 160. And they have given the way how to treat with statin and or lifestyle modification. This is one more from CSI, Cardiac Society of India. They have categorized primary prevention into 5 groups: low, moderate, high risk, very high risk, and extremely high risk. And based upon, they have given the target level, just like low risk LDL less than 100, moderate risk 100, high risk 70, and very high risk 55. This is how they have done. And we all know about the European Society of Cardiology guidelines. They have clearly mentioned that in primary prevention, for individuals at very high risk, LDL reduction should be more than 50% from the baseline, and LDL goal should be less than 1.4 millimole per liter. And individual who are at In high risk patient, LDL reduction of more than 50% and the LDL level goal of less than 1.8 are recommended. And this is the recommended for European Society, and they have this chart which helps us to find who are at which risks and how they should be treated. And this is the famous from ACCHA. So how they decided is if LDL level is more than 190 or diabetic, and then you have to go for statin, but the level of giving statin is different. High intensity in more than 190, moderate intensity in diabetes mellitus, and based upon the risks, they have divided into low risk, borderline risk, intermediate risk, and high risk. And based upon that, they start statin. In Nepal, we don't have any guidelines or consensus document on lipids, but Cardiac Society Nepal has formed a committee to formulate a consensus document on lipids. So most probably in coming 2025 May, we will publish our first consensus document. How these guidelines are similar and different? They have common theme of primary prevention, risk calculator algorithm. Most of them have their own healthy lifestyle. They promote healthy lifestyle, but what are the difference? They use different score system, just like NICE score, a NICE guideline use Q score. European guideline have their own. Japanese physician, they have their own one, and then American, they have their different one, and the different plans is different. Somebody had a target goal. Somebody said that start high intensity and moderate intensity treatment, no risk calculator algorithms and treatment plan depending on the country specific evidence base. The only is from Japan, and lipid parameter goals are different. These are the risks used, and why did these risk scores have problem? Because ACCSA equation for estimate 10 years risk for ASCVD event applies to black and non-Hispanics, white and male between age of 40 to 79. But this risk predictor may overestimate in Chinese population. It may over or underestimate in shorter groups such as those with obesity, black adults, and South Asian adults. The Framingham score, which is the first score, it overestimate the ASCVD risks for the ethnic Chinese. It may over or underestimate in shorter group, just like others. So factors such as family history, which is one of the strongest risk factor, and social determinants of health and physical activity are not captured in this score system. And the more important is younger individuals, that is less than 40, that they don't qualify for use in ACC risk category. Let's talk about the management of dyslipidemia guidelines. They said that risk assessment, lifestyle modification, and medicine for all the individuals with elevated cholesterol, or even the healthy individuals should go for lifestyle modification. And there are many medical therapies to lower the LDL level. So lifestyle modification, I think I don't need to explain much about this, because we all know. And among the medical therapies, the LDL to reduce LDL level, statin are the first line and mainstay of therapy for both primary and secondary prevention, because they have a lot of evidence. You can see how it works. And statin, they can be classified into moderate intensity, high intensity, and low intensity. We usually prefer high intensity statin in most of our cases, especially those with secondary prevention and high risk cases of primary prevention. And what is the difference is moderate intensity statin reduce the risk by approximately 1/3, while as high intensity statin lowered by about 1/2. But the thing is, the absolute reduction vary between the baseline LDL level. This is one of the most important slide. For a baseline LDL of more of 200 milligram per deciliter, or 50% reduction equals to around 100 milligram per deciliter decline. This translates to 59% reduction in the 10 years of risk of ASCVD event. In contrast, in a patient with baseline of LDL, 100 milligram per deciliter, or 50% reduction equates to 50 milligram per deciliter, and declines which reduce the ASCVD risk by only 30%. So more the reduction at lower level LDL reduction, progressive reduction of LDL produce diminished benefit from the cholesterol lowering therapy. This modifies the aphorism of lower is better. What does that mean? There are diminishing benefit from intensified cholesterol lowering therapy when LDL levels are already low, and one needs to balance the benefit of further reducing LDL levels with the risks and cost of additional therapy. And PCSK9 is one of the therapy which can be used to lower the LDL level where statin itself is not effective. Ezetimibe is under drugs that can help us to lower the lipids level, LDL level. This is a new drugs. It also helps to decrease the LDL level. And let's discuss about the treatment goals of LDL cholesterol lowering for primary prevention in different categories. Severe hypercholesteremia is defined as LDL more than 990 milligram per deciliter. It increases the CVD risk by 5 to 6 fold, and CAD develops 10 to 20 years earlier in men and 20 to 30 years earlier in women than in the general population. It should promote evaluation for familial hypercholesteremia, and approximately 7% of this category of patient can fulfill the criteria of familial hypercholesteremia, and they are high risk and they don't require 10 years risk estimation. So genetics testing should be considered in those group of patient, and we need to start lipid lowering at early age to decrease the morbidity and mortality. And how to manage them? High intensity statin. And if with high intensity statin the lipid LDL is more than 100 per deciliter mg per deciliter, we need to add ezetimibe. And even after ezetimibe, if we are not able to achieve, then we need to add PCSK9. And this is about the familial hypercholesteremia, and this is what the guideline. They are almost similar in all aspects. Even Asian Pacific Society of Cardiology consensus recommendations are almost same. And diabetes, we all know that diabetic patient, there is a complex alteration of lipid profile, and LDL is the primary target of lipid lowering therapy in this patient, and we need to achieve LDL goals in patient with diabetes. At least it is as important as glycemic control and blood pressure control. So we need to check LDL level, cholesterol level every 1 year. This is the guideline. They are almost same. Those patients should be treated with moderate intensity statin, and if they could not achieve a 50% reduction, then we can go for high intensity statin. This is especially more than 75s who are on statin, it's reasonable to continue the therapy. And whereas new initiation of the therapy should be based on the clinical patient discussion, and patient who are diabetic and age between 20 to 39 may be considered for statin based on the duration of the diabetes and renal markers. Why we need to treat them with statin is because of the high risk. So these are the same. And primary prevention in adults with chronic CKD. So all the patient with CKD 3 to 5 should be treated with high or they are considered high or very risk as per ASC guideline, and they say that directly we go for statin or statin plus ezetimibe combination is recommended in patient with non-dialysis dependent stage 3 to 5 CKD. ACC also says the same thing, and those high risk patient, that is the risk of more than 20, we need to use high intensity statin to reduce the LDL level of 50%. And if in those with high intensity statin are recommended to reduce by more than 50%. Intermediate risk, moderate intensity statins we need to use. Low risk, we need to go for lifestyle modification. In those 75 and above, primary prevention in those above 75 years requires shared decision making. And the role of statin in elderly, that is more than, is less certain, and thus their use must be tailored to every patient after discussing the risks and benefit. This is the ESC guideline, how based upon the risk factors and the level of LDL, they have given this recommendation. And this is all like the previous one. So what is the issue with ACC-AHA is that they don't have the numerical targets. The only expectation was that recognition of LDL level threshold of goal of 1.8 millimole per liter for consideration of PSK inhibition in very high risk patient on maximal statin plus ezetimibe. That is the only threshold given by ACCHA. ASC guideline, depending on the 10 years ASCVD risk, they decide the treatment, but what they have done is they support the 50% reduction, not only 50%, but they recommend for less than 1.8 millimole per liter, and for very high risk, less than 1.4 millimole per liter, and moderate risk 2.6. This is ASC guideline. It's very clear that when to up titrate and when to add other drugs apart from statin, and why we should aim low. Meta-analysis have shown that for every millimole, that is 30 milligram per deciliter reduction in LDL with statin, there is an approximately 22% reduction in ASCVD events, and other reports showed that an almost identical relation holds when several different kinds of LDL therapy were analyzed together. So are we Asian different? Yes, we are different. Asian respond more strongly to statin as compared to the Western population. No ethnic, white or Caucasian required a higher dose of statin when compared to Asian. And it has been shown that the maximum prescribed dose of atorvastatin in Japan is almost half of what is prescribed in a US patient. And meta-analysis reported that Asian required statin administration for a much shorter duration when compared to the Western population to achieve the same level of lipid, and multiple reasons has been cited for this. And in conclusion, ASCVD is the leading cause of morbidity and mortality worldwide. Dyslipidemia is strongly associated with the pathophysiology of ASCVD. LDL lowering is important dyslipidemia management in the primary prevention of ASCVD, and different treatment goals of LDL level is in different category counts. Thank you. Thank you very much.
Okay, thank you, Dr. And I covered a comprehensive review regarding the primary prevention, and the show is the different Asia guideline targeting in primary prevention and medication now we can use. So any question from our audience?
Yes.
Yeah. Hello.
Yes.
Can you hear me at all? Or?
Yeah, I can hear you.
Yeah, look, thanks very much for a very comprehensive presentation. Sorry, I got to do this on my telephone. My name's Gerald Watt from Perth in Western Australia. Yeah, I enjoyed your presentation. It was a big ask to cover all those guidelines. I just want to ask you a general question and then a specific question. One of the challenges in guidelines is that, believe it or not, the majority of these guidelines are never implemented, really. It's every guideline is written, everyone thinks that's the way it's going to be, but if you look and follow it up, the implementation is very poor. And my question to you is, what can be done in individual countries to improve implementation of these guidelines? And the other related question is, how many countries actually develop their own risk equations? Predicting risk is important. And the third question is, what is your opinion role of cardiac imaging in redefining primary prevention? Lots of questions there, but what do you think?
In my opinion, just like there are only few countries, they have developed their own risk scores. It's like I think in Asian country, Japan, they have that Suita score, which is very easy to use. I feel it's very used, but I have not gone through it in detail, but it's very used. Apart from that, they don't have. In India, they have they don't have the score, but they have some criteria. With that criteria, they help to differentiate high risk, low risk, but they don't have the numerical value on them. But I hope that with the development of so many techniques and technology and research, I think every country can have their own this risk system in the future. I hope. And what you have asked is, second one is the imaging.
Well, let's talk about the imaging, and then I'll talk about implementation. Really.
Yeah.
Yeah.
And regarding the imaging, yeah, they have guidelines, just like in LI and also in CSI and other guidelines, they are included coronary calcium score as one of the risk factors or enhancing risk factors. It helps, but the country like ours, well, where financial is a real issue, I think we should stick in those criteria where it's easy to use. We don't require hi-fi technology to implement those guidelines. Yes, probably it's a better option, but due to the financial issue especially in South Asia, I think there is a speaker from India also, how much it will be useful, but how many people will go through it, and it adds on cost. So that is another issue in our part of the world. And yes, what I felt is we are trying to write one guideline or consensus document in Nepal also. So what I feel is statin is overused in those cases where it should not be used based upon the guideline, and it's underused. And that means in those cases where we have to use, doctors or physicians aren't going to use. So we need to we need to streamline our physician that okay, these are the group where you will get the maximum benefit, and these are the gray zones, so it's not beneficial. So we need to be in that age that where the patient will get benefit. And the other part is, as statin, they don't have any symptomatic benefit. Those cases who have to pay themselves, and as it doesn't give any symptomatic benefit, they are the patient who are very difficult, because they feel that it doesn't give any symptomatic benefit, so they may just give up those drugs. So that is the issue in our part of the world.
With the permission of chair, I'm Dr. Sani. Can I make a comment? And
sure, please.
Sure. Okay. So we have just released our first guideline of the country. So far, we had only consensus opinion and expert opinion based on Western literature. But our guideline based on our Indian population, we must admit we did not have our calculator, and Western calculators, they are underestimating it. So we use only the risk factors. My question to Professor Watts, sir, you have raised a question about the imaging. I think we are using a lot now in our clinical practice. My question is, I have got an asymptomatic patient with multiple risk factors, and now I did a CT angiogram. Calcium score is around 350. His LDL is, LAD is 60% block. So is it a primary prevention or a secondary prevention?
Well, I mean, I think ethically, you treat patients. I mean, I think the division between primary and secondary prevention is very much a political one, actually. It behoves us, the excellence of care is patient-centric. I mean, what you described to me is an extremely high-risk individual, and I would treat them as if they were in secondary prevention. I think you raise an important point, Dr. Professor. I mean, you raised the point, you did a CT coronary angiogram. Calcium score is not enough. I mean, I can tell you 3 cases in the last month of people, calcium scores of 0, admitted with severe anterior infarcts, really. One in ICU and balloon pumping. I think if we're serious about really going into depths of what risk is all about, really, I think we have to do CT angiography. But then again, we are limited by resources, and we got to be practical. In short answer to your question, secondary prevention, without doubt. I mean, the meniscus between primary and secondary prevention is very thin, and it's very thin because we don't know what's going on in the arteries. I think, and in time guidelines have more imaging. There is no doubt that. I mean, I don't know whether you remember many years ago there was a guideline was proposed that you start with imaging, and then after you've done the imaging, you then do the circulating risk factor clinical assessment. And I think that SHAPE, it was called SHAPE, guideline to cardiovascular risk, and unfortunately it didn't take off.
Yeah, I think, thank you, sir. I've got experience that I've got a lot of patients with calcium score more than 2000. And when we do a coronary angiogram, found lesions are insignificant. I mean, 10, 20, 30%. So that is also one side of the story, as you said rightly. Non-calcified soft plaque can also rupture and cause myocardial infarction. In my personal view, I think you correct me. I personally feel now, if we add imaging to our prevention secondary and primary definition, then any atherosclerosis which is picked up by the any method, I mean by the carotid Doppler or by CT angiogram, if there is a atherosclerosis sets in, I think that patient should move into a secondary prevention category. Primary should be strictly one where we have prevented the atherosclerosis. The one we are just managing the risk factor and preventing the atherosclerosis. I mean, this is my view. I'm just asking your thought on that.
No, I think you're absolutely right. I mean, your calcium score of 2000, these are fascinating people. I mean, some of them are athletes, some of them are marathon runners who swim, 20 lengths of a pool a day. They've just got a lot of calcium score and they want to know why. And that's the challenge, this notification. I often say, well, you've done so much exercise that you've converted cholesterol in your coronary arteries to calcium, which is a good thing. You're doing a angiogram, there's stenotic lesion, the stress is super normal, the exercise to 20 minutes with good cardiac function. It's a fascinating situation, that one. But I mean, sorry, I don't know, this is a really good conversation, but is Dr. Lou Santos, she present or not? Because I don't know whether
I think the first speaker could not make it, so I was the first to present.
All right. Okay. So we've got a little bit of time to talk about that. Other end of the cardiovascular risk prevention spectrum is prevention, ultra prevention, primordial prevention in mothers to make them healthy in order to prevent development of unhealthy infants. And the assessment of risk in children and to children, adolescents, and young adults up to the age of 30 be risk assessed and take appropriate treatment. I don't know what the strategies are in your country, management of cardiovascular risk in the young.
Yeah, I think in our guideline, we stratified that the first lipid profile should be done at the age of 18 for general public. The moment a child goes to college, he should know his sugar, he should know his blood pressure, he should know his lipid. Because in our country, we get all the risk factors almost 10 years earlier, including obesity. And that leads to the early onset of disease in our country. Besides that, familial hypercholesterolemia, in our good data we have got now, large number of population, more than 15% of the young heart attack patients, which are 50% and above in our country compared to Western world, only 15%. We found more than 15% of the young heart attack patients have FH. And in their index case children, we asked them to go for lipid at the age of 2 even. But for general public, we have suggested to go for 18 to identify all the risks. So the earlier we pick up, early we modify the risk factor. And maybe some of the children, they need statin, because they have got multiple risk factors, which is we are seeing these days. Heart attack coming in 25 years, 28-year, 30-year-old boys. We are seeing a lot of them in our country now in India.
Because of pandemic, I'm sorry, I should close the first section because Dr. Was is online and Dr. Santos from Philippines is still not online. So maybe I will switch in the chair role to Dr. Was to introduce the third speaker, Professor Biyan Liu. Dr. Was, please.
Oh, yeah, okay. Thank you very much. And apologies for, I'm doing this on the phone. The phone, the university computer does not really. So it gives great pleasure to introduce Professor Biyan Liu from Taiwan. Is that right? Professor Liu, talk about the new paradigm, statin resistant, or statin intolerant LDL lowering therapy, and he focus on monoclonal and gene silencing therapy directed at PCSK9. He's going to review bempedoic acid and the new PCSK inhibitors. All yours.
Okay, thank you. Right, I heard that. So thank you for your introduction, Dr. Wards. I'm Dr. Liu from Taiwan. So now I'm going to present my talk. So the topic that I received is a new paradigm in statin resistance or statin intolerance with LDL cholesterol lowering therapies. So it's very interesting that the previous speaker has mentioned about Taiwan skyline, particularly for the second prevention or prime prevention one. So I'm currently the Secretary General of Taiwan Society of Lipid Atherosclerosis. So I would talk this talk by 3 ways. The one is, or we talk about the statin intolerance first. So what is the prevalence and also the natural cause of the statin intolerance? And then we'll talk about some available LDL lowering therapies for statin intolerance. And there are some future technologies. So I mentioned that some of the technology were also mentioned by the last speaker. So I will talk about the statin intolerance first. For the clinical practice, as mentioned by the previous lecture, there are many guidelines recommendation, lower and the lower LDL for patient either by primary prevention or second prevention or other diabetes. And so as a lower for the LDL target, we are going to reach it. So the statin intolerance will comes up intermittently. When we go for the clinical one, some patient will complain their back pain, and some patient complain muscle ache after taking the statins. But unfortunately, we have to advance the statin for them. This is the guideline as mentioned by the ESC and the EAS few years ago. They try to lower the LDL for high-risk patient. They are very high-risk patient, and also those who with a repeat intervention for, particularly with the diabetes one, they are requested to have a 40 milligram per dL for the LDL target. So as the LDL lower very aggressively, when we treat a patient either by their criteria or by their disease, and then we sometimes met patient with statin intolerance. Our society also have 2 guidelines. One is 2017, one is 2022. So at that time, when we patient have the acute coronary syndrome, then we request them to have a lower LDL target. And also, we also set the PAD or stroke patient with lower LDL target recommended by our guidelines. And in other society in Taiwan, that is the Taiwan Society of Cardiology. This guideline, they don't want to argue about the primary or second prevention. So there is a chronic coronary syndrome patients. So those who, for example, the question that the doctor was discussed about those patients with coronary angiography with calcification or minor atheroma, they were divided into the chronic coronary syndrome. So we have a logo here. One is a multiple myocardial infarction, that is a C, and one is V, that is multivessel disease or polyvascular disease, and D is particularly with the diabetes and acute coronary syndrome. So those patients, they probably need to have lower LDL levels. And also we suggest some PCSK9 inhibitors or a combination with a higher intensity statins and acetamide for these patients. So among these patients, sometimes we will meet patients who cannot take statins. What can we do? So statin intolerance is a symptom, and some of them, most often the symptom is a statin attributed muscle symptoms, so we saw SAMs, and some of them will have GI symptom, fatigue, peripheral neuropathy, insomnia, or cognitive functions. So this kind of statin intolerance sometimes is not very specific. So you need some criteria to define the statin intolerance. Previously, there is a criteria to stratify the severity for the statin intolerance or myopathy, and from no symptom to have a CK higher, or sometimes with rhabdomyolysis, sometimes very severe. This is a previous criteria for everyone. And as those who cannot take statins, either by stop the statin or intolerance to the statin treatment. sometimes they will discontinue statins. We all know that this kind of discontinuation will increase the death of either any cause of cardiac death or non-fatal myocardial infarction. So it's very, very dangerous to stop the statin by themselves or without, no, they don't adhere to the guidelines. And also there are several observation studies showing the higher dose statin studies, for example, atorvastatin, simvastatins. If they took higher dose of statins, the symptom with muscular symptom will be increased and the odds ratio will increase significantly. So when we know the patient took higher statins, those statins, particularly the previous simvastatin and currently atorvastatin, if you have a gene background like SLCO1B1 genotype, your risk for myositis or myopathy will increase accordingly. If you have a CYP415 inhibitors, or you take alcohol, grape juice, or cocaine, sometimes the concentration will also increase. So when we treat a patient with statin, probably he has coronary artery disease, right? So sometimes we'll combine with aspirin, lipid-lowering therapy, beta blockers together. But when they have a statin intolerance, they cannot tolerate the lipid-lowering agents. Sometimes they will take all the medication off. It's very dangerous, right? So we can see that those who, when you have a observation study, those who patient stop statins, and if they took statins under certain period of time, you have a longer statin treatment, your risk is lower. Compared with less than 10 days, the time covered with statin therapy. So if you skip the statin, the risk will be increased and you will lose 1/4 of the protection for your heart. So in summary, the statin intolerance, the prevalence according to the Caucasian population is 7 to maybe 6%. But in our real world, sometimes it's higher. There is a risk. So in the pink one, they are increased for statin intolerance. One is Asian race. The other one is Asian. Another one is female. And there is a higher statin dose will also increase the risk. Finally, if you exercise, sometimes they will increase the risk. So maybe it's not true for statin intolerance, but the data showing that, so our Asian population actually is a very high risk for statin intolerance. So in our society, we also have a consensus study on statin intolerance. So we divided into different guidelines. They have a different definition for myopathy, myalgia, and myositis or rhabdomyolysis. So as a severity for the CK is higher, and then the risk for the life-threatening also increase. So it should be very cautious about the definition for the statin intolerance. So we have a flow chart for physician to follow which one is really statin consensus. It's very complicated. But when you have a, for example, you have a CK higher, you have to withdraw statin, and then when the symptom recover, you have to check the enzyme again. If the enzyme is higher, then you need some muscle biopsy. So follow this strategy, you probably can find out the statin intolerance. However, the patient cannot wait. And also physician maybe not so patient. So then we probably need some tools to treat the patient who suffer from statin intolerance, but actually they need LDL lowering therapies. So the topic for me is to discuss about the ezetimibe, PCSK9 antibody, bempedoic acid, and PCSK9 oral inhibitors. So this is a very complicated biochemical development for the cholesterol metabolism. But with the effort from scientists, we found several important medications. Statin is the usually we did. So there are several medications, either from the PCSK9 pathway or LDL lipase pathway, or the absorption from the intestine. So the most common and the most, the old friend for us is the ezetimibe. It is an NCP1 inhibitor. So this one, I think most of us have used it with a combination or alone. It inhibits the resorption from the intestine, so they will not go back to the liver, and also prevent the reabsorption for the LDL or very low LDL. According to the previous study, usually, in addition to statins, ezetimibe will lower 70%, or sometimes we say 20% of the LDL. And the most outcome study is improved study. So as we know, those patients who suffer from acute coronary syndrome will divide it into simvastatin or combined with ezetimibe by simvastatin. Finally, the combination actually lower the LDL level very successfully. Their outcome also successful. So the significantly lower the prognosis for those patients who suffer from acute coronary syndrome by combination with ezetimibe. So I think if patient who has intolerance for the statin, usually the first step we use ezetimibe for those patients. But so a few years ago, there is a PCSK9 inhibitor antibody comes out. There are two companies. So they use this kind of injection therapy to neutralize the PCSK9. They can increase the LDL receptor and also lower the LDL cholesterol levels. So everybody knows there are two large studies. And one of the study, there is alternative or option study for the atherosclerotic. So this kind of PCSK9 inhibitor, they're showing that if you compare PCSK9 inhibitor and also the ezetimibe together, you can lower even more the LDL patient with statin intolerance patient. This is ODACE alternative study result. And also in the other PCSK9 inhibitor, there is evolocumab. There's a GHOST-3, GHOST-4 study. So both trends are very similar to the previous one. So they lower the LDL to maybe 54% of the LDL one. This is also very similar trend. So I think the PCSK9 antibody for the injection one is very similar in two medications. They can lower more for the LDL level with compared with the ezetimibe one. So it's more stronger. And but you know, there must some development of new drug. There's a bempedoic acid. I think everybody knows these new medications. It acts on the ATP citrate lyase. This kind of inhibitor is upstream of the HMG-CoA reductase. So they will be upstream for the LDL production. And also it doesn't exist in the muscle. So it's very interesting. They can inhibit the LDL production, but they didn't exist in the muscle. That is probably the why this kind of medication will not cause muscle symptoms. So this is another figure. With the liver, they have this kind of enzyme, but in a skeletal muscle, they don't have ACSVL1 enzyme. So bempedoic acid will not act on the muscle, skeletal muscle one. That is why the adverse event for the skeletal muscle will be very limited. How about the lowering effect for the LDL one? So there are two comparisons. One is for the hypercholesterolemia with tolerated statin therapy. They can lower LDL more with 15 to 16%. And the other CLEAR trial, they also use patients who cannot tolerate statins. So the hypercholesterolemia level will lower even more significantly by the bempedoic acid. And also they found very interesting that high-sense CRP, the inflammation also lower in these patients. So they probably not only lower the LDL, they also have additional benefit for the cardiovascular system. The most important study will be CLEAR outcomes. There is more than 10,000 patients compared with placebo. So CLEAR outcome study, they compare, they study patient, they claim that they have a statin intolerance, or they refuse to attempt a second statin or by the physician. So those patients may not truly statin intolerance, but they try to another medication, that is bempedoic acid. So interestingly, they lower the LDL by 26%. So additionally, then maybe 20% lower compared with the placebo one. So they can lower the LDL with statin intolerance patient. And also the outcome will also improve in clear outcome study. So not only LDL lowering, but also the outcome was improved. So finally, I will talk about the increasing. Increasing is fully chemical stabilized duplex RNA. So in addition to PCSK9 neutralized antibody, they also have an mRNA product here. So they have a conjugated with a GalNAc conjugate. And this kind of conjugate can directly into the hepatocyte. So this kind of subcutaneous injection, they have a very long lifetime. So here is the mechanism for the increasing. With the siRNA, they will bind to hepatocyte via GalNAc structure. And then this siRNA will penetrate into the liver, and they will stabilize in a risk, that is RNA-induced silencing complex. In your cells, they will retain in the guide strand, and then we'll find a target for the PCSK9 mRNA the segment, and they will pair with them. Finally, they will degrade the PCSK9 mRNA. So finally, in your blood, the PCSK9 will be lower. That is why we can lower the LDL level in your bloodstream. Several studies has been done, Orion 9, Orion 10, and Orion 11. And also they have a ASCA, high-risk ASCA patients. So there are several studies, they calculate the Asian study population. They have more than 300 patients. So we can see whether increasing by the injection of mRNA can also lower the LDL or not. So interestingly, the LDL level goes down after almost 1 year. So the efficacy is very strong. And also they can, almost 60% of the patient reach the target for LDL lowering. So it should be very effective, but the long-term prognosis should be observed. Without starting population and with starting population in increasing study, they lower the LDL very similarly. So even you are intolerant to statin, the LDL still can lower. And also the muscle pain or the muscle ache or liver enzyme elevation, they are very similar to the placebo one. So I will talk a little bit about the future technology. So it's the same population with statin intolerance. Can we use other one to treat that? So one is oral PCSK9 inhibitor. I think it's under clinical trials. Our hospital also involved in this kind of studies. So they try to lower the LDL by oral PCSK9 inhibitor. I don't know other country, but in Taiwan, if you want to inject medication for this patient, they are very resistant. They don't want injection medications. But you see here, the efficacy for the oral PCSK9 inhibitor is very effective. 60% of the LDL lowering. So it seems very effective. And also there is an oral CPD inhibitor. They can lower the LDL levels. And also if you combine with ezetimibe, the efficacy will be like 40% of LDL lowering effect. There are two medications are currently online. This is siRNA with angioprotein 3 and ApoC3 silence RNA. I think the LDL level may be not so lower, but TG is very effective. I think the other speaker will talk about this later. So there is a normal technology, that is the CRISPR technology, gene editing. Gene editing, they can use for the PCSK9 DNA. This kind of study we call HAR1 study. And the injection is only once a life. So very effective. The LDL also lower 60%. So don't worry. So this patient who has a statin intolerance, in the future, they probably have several tools for this one. So we can have a therapeutic antibody, siRNA, small molecules, or other RNA with CRISPR editing for the genes. But the safety remains another issue for our physician to mention about that. So we probably need some long-term study for this kind of novel technology. So in summary, there is a trend that ASCVD patient or second prevention one, the lower target for LDL seems strict. So we should treat patient with very aggressively. From previous statins, there are 30% of LDL reduction, bempedoic acid maybe 20% with ezetimibe, and high intensity statin are 50%. PCSK9 are very effective, but if we combine ezetimibe or statin or bempedoic acid, so those patients cannot tolerate statin, then the other one, they still very effective for these patients. With the lower, the better theory, I think lower LDL is our target to do. These medication or effect, they remain underlying. That means we lower the LDL with any kind of intensive strategy. Probably we can save patients' life. And finally, when you treat the patient with LDL lowering, if you keep patient treatment longer, the effect will be better. So not only treat the two target, but also we have keep the longer time when we treat the patient one. So the side effect for the statin, for the statin intolerance may be higher than our expectation. And we available LDL treatment for patients. There are many kinds of medication we have mentioned. And also we have to prove the effective with effective maybe 20 to 60% of LDL reduction. The safe in clinical status among statin intolerance have to be observed. And with the newest paradigm shift concept, LDL better for lower, longer, sooner. So the novel therapies and the combination, they are our crucial tools to treat our patients with statin intolerance. With that, I thank you for your attention.
Thank you very much indeed, Professor Liu. So I'll take questions and I'll hand to my co-chairman to introduce Dr. Sohoni from India. So let's have a couple of questions for Professor Liu.
That's right. I think I want to make a comment that the statin intolerance very nicely, Dr. Ping Liu has shown in his presentation. Right. It is overstated. I think many times media plays a role. This is what I've seen. And we have no data to show that. The LDL variability also comes up because of the statin intolerance. Patient keeps on stopping the drug, restarting it. Something to that variability of the LDL also starts looking into the increased cardiovascular event. There is a good paper which shows like BP variability, diabetes variability, similarly LDL variability is playing a role also. Now in our country, what we are finding now that the inclisiran is taking up as an alternative to the PCSK9 monoclonal antibodies, right, because of 2-3 reasons. One is the adherence, 2 injections versus 26 injections. Second is the less of LDL variability, because with the incretin, what we are observing a constant reduction of maybe a little less effective than PCSK9, which reduces LDL by 60%, incretin by 50%, but there is very less LDL variability. And another important cause why this drug is having more acceptability is probably the cost factor. In our country, this is more affordable compared to the PCSK9 inhibitor. Ezetimibe and bempedoic acid and statin all are generic. And the triple combination we have experience now in giving to our patient of familial hypercholesterolemia. And in spite of giving triple combination oral drugs, many patients do not reach the guideline-directed goal of less than 55. Then we have to pitch in one of these PCSK9 inhibitors.
Right. So I totally agree with your opinion that stability for the lipid lowering is very important. And because previously probably we don't check so frequently for this patient with the PCSK9 inhibitor antibody, but the increase in data is very stable. So when you treat the patients, combined with statin, bempedoic acid, etc., when you treat the patient with incretin, sometimes you can tap off some of the medications. It remains very stable. So I totally agree with your experience. Thank you for your comments.
Thank you.
I'd just like to make a point about statin intolerance, in particular myopathies, that it's important not to miss an underlying cause of an inflammatory myopathy by examining the patient adequately, being quite rigorous about the distribution of the pain, if there's any weakness, screening for autoimmune conditions like dermatomyositis or the complex that can occur with systemic lupus erythematosus. The other factor, vitamin D deficiency, vitamin levels less than 20 nanomoles per liter are associated with these incidents. I mean, these things are rare, but before jumping in and saying, you know, this can't take a statin, it's an intolerant, I've got to come up with a reason why that isn't the case. Professor Penyen Liu indicated the many risk factors for statin intolerance. And I think in Australia, there is a problem. I see many Asian patients discharged from coronary care on 80 milligrams of atorvastatin because they come to the clinics, you know, over with full blown statin intolerance. And it's we have to be aware that, culturally aware that, as was indicated, that one has to use a different type of statin, a lower dose of a statin in those particular groups. I think that most people who seem to be statin intolerant, in my experience over time, you can get back onto a level of statin and low dose, low frequency statin. You can get them on that. It's important because it increases the efficacy of the PCSK9 directed therapies and therapies. You know, many patients get the idea that you're going to go injectable. That's it. You know, the background with a statin or even a natural statin will make the injectable more efficacious. I just say one final thing before we on to another question. Inclisiran is not without side effects. You've got to be quite clear at the moment. It's new. Every cardiologist in town is now using it. On they go, and it's been what we call an Indian summer. Actually, for the first 4 weeks, the Indian summer is a lovely time of the year. For the first 4 weeks, or it's a honeymoon actually. But already, you know, the number of people going inclisiran, they have, you know, a few concerns about intolerance, even that. And that's an important thing when starting a patient on a drug lasts 6 months and longer, that inform them, you know, what potential side effects are. I think in my experience, when you say, you know, because a lot of the people who want to inclisiran will be people who have been on drugs before, when you actually put it to them, say, look, this is a drug that's going to be active for 6 months. If you do develop a side effect, we won't be able to reverse it. It may go on for a long time. I find that while you tell them that, many people shy away from going on inclisiran. In Australia, at any rate, it may just be in Australian perception. But those difficult patients who are intolerant to many drugs, they are reluctant. I just want to think that I know it's a little bit extreme, but for people with high LP-little and very high LDL cholesterol, the refractory treatment, lipoprotein apheresis is a very effective way if you've got the resource, and there is evidence with apheresis that you get a reduction of risk with intervention. Especially, there's a randomized control from the Brompton School done by Dudley Pennell and Khan, showing that if hypercholesteremia and refractory angina, apheresis is very effective.
Thank you.
Thank you.
I think I want to make one more point I want to discuss, may not be statin intolerance. While preparing our guideline, which we recently published, we experienced that in our country, atherogenic dyslipidemia is high. metabolic syndrome is high, truncal obesity is high. So what we found in our guideline that the new onset of diabetes, which is there approximately 9% of patients, which is dose dependent. While preparing our guideline, what we found is significant number of our pre-diabetic population, those who have had HbA1c around 6 in the beginning, after starting high dose of statin with ezetimibe, then we found over a period of 3 months follow-up, the HbA1c starts showing rising trend. Some of them, they cross 6.5 also. And in that situation, it may not be statin intolerance, but yes, there is a new onset of diabetes. So we suggested to reduce the dose of statin to half. And if the LDL goes above 55 in subsequent lipid profile, then add bempedoic acid as a drug, which probably has less effect on the blood sugar level. But to maintain the LDL below 55 and adding a small dose of statin and bempedoic and ezetimibe probably gives us a safe strategy to prevent new onset of diabetes in our population, because this is a very large number of population in our country.
Well, I see. It's a very interesting point. But so my point will be, so is any try to showing that when you have a higher HbA1c with going up, when you change into bempedoic acid, the outcome will remain the same one? There will be a remain open question for everyone. But I believe that every patient, they are curious about their HbA1c. When we check that and say that your HbA1c was higher, they are very anxious. So your strategy maybe is good, but it depends on how much is the bempedoic acid and whether the outcome for the hard endpoint is remain positive or not. Thank you for the comments.
Yeah, thank you.
Yeah, I wonder, no, these are really good points. I mean, we probably need to move on to the other speaker, but I wonder whether I could ask the opinion of Professor Liu in with the clear outcome study, which the majority of people, almost all of them really, but some were on statins. The secondary analysis carried out in JAMA cardiology in a primary prevention setting actually, appeared to show, a significant reduction in MACE and in cardiovascular mortality outcomes that appeared to be greater than in the secondary prevention cohort. What was your interpretation of those data? Actually?
So you talk about the clear outcome, right? So
yeah, not that the clear outcome was the follow-up study in this and in cardiology. The main study was in was New England. There was a follow-up study that I think you showed there, which was in primary prevention cohort. A really quite marked reduction in the hazard ratios, including, all-cause mortality. And how did you interpret that, really? Primary prevention cohort is showing quite a more marked reduction in relative risk compared with the second prevention cohort.
Right. So there are some discussion about the primary prevention or second prevention. Which one is better for bempedoic acid treatment with a very low dose statin baseline? And as you mentioned in JAMA cardiology, I think that the initial observation outcome maybe not so. I don't know whether the power is significant for the analysis or not, but those patients they don't have they don't have any other choice for the higher dose statin, so they were randomized to bempedoic acid add on the low dose statin or not. So I don't think the result will be applicable for all primary prevention or all secondary prevention. So one study, maybe we need more study to calculate more data, maybe in the real world data. So I think Dr. Lin also have some experience on the bempedoic acid. You want to comment something on this one?
Yes, I agree with Professor Liu's suggestion. Because right now we have only limited outcome data for bempedoic acid. So I think we should need more data, maybe real-world data to prove the role of bempedoic acid in primary prevention or simple primary prevention or simple secondary prevention population, not only in the
Yeah, I mean that was interesting. I mean, what was particular about that population compared to other studies? That about 60% of the population were women, actually. So whether this is something specific to primary prevention amongst women with multiple risk factors, maybe at high risk, I'm not clear actually, but it does remain as something for further discussion. And on that note, coming to the time, I'll hand over to my colleague, Professor Xu Xian from Taiwan, introduce very engaging from India, Professor Sohor.
Okay. So let me introduce the next speaker, Professor Savani. Professor Sony is from ex-member Derby Medical Council. Currently, he's a professor, senior consultant cardiology, and the chairman Department of Cardiology, Sir Gangaram Hospital, New Delhi, India, and the member board of Management Executive Board, ASCVD, and the Research Committee, SGRH. Today, Professor Sony will give a talk entitled Treatment Goals of LDL cholesterol lowering for Secondary ASCVD Risk Reduction, different cardiovascular risk category counts. Professor Sony, please.
Sure. Thank you. Thank you. I'm going to share my slide. So thank you, Professor Lane, and thank you, respected chairperson and dear friends. Good morning and good afternoon for somebody, some of our colleagues. And first of all, I'm thankful to the APSC Cloud Forum in Cardiovascular Disease for giving me this opportunity to discuss with you the treatment goals of the LDL cholesterol lowering for secondary prevention to reduce the atherosclerotic cardiovascular risk reduction. Does the CVD risk category matters? So these are my disclosure and conflict of interest. And as you have already heard from my previous colleagues, that the cardiovascular benefits of aggressive LDL lowering with statin has been studied in both primary and secondary prevention trial. And we have observed that there is a log linear relation of the LDL lowering going down below 70 milligram with the reduction of cardiovascular events. And this has been studied with the meta-analysis of all the secondary prevention trial. And they have observed now that if you reduce 1 millimole LDL cholesterol over 5 years of trial period, there is a reduction of cardiovascular events by more than 20%. So what we learned over the last 3 decades, starting with one of the important 4S trial, then CARE study, lipid study, that the average cholesterol is not good. And even bringing it down to LDL cholesterol of less than 100 milligram with moderate doses of statin did reduce the cholesterol, the cardiovascular events, but it was not enough. And in 2004-5, we got the 2 important studies, the TNT and Prove It trial, where they have used the high-intensity statin doses, maximum doses of statin, and targeting below 70 milligram resulted in further reduction of cardiovascular events. So that was the plateau of the statin doses at that stage. And then we have the data from both primary and secondary prevention trial that in spite of this achievement, the residual cardiovascular risk persisted. So we started looking into the other therapies, other non-statin therapies. And from the meta-analysis of both the therapies from the statin as well as non-statin drugs like the ezetimibe at that time and the PCSK9 inhibitor, they have clearly shown you reduce 1 millimole of cholesterol either by statin or by non-statin, there is equal reduction of cardiovascular event by 21 to 22%. So that was an important finding which we learned. So first study which Dr. Leo has already discussed about the IMPROVE trial, where HTMI was used along with simvastatin moderate to high doses in 18,000 patients with acute coronary syndrome with the baseline LDL above 90 and going down to below 70 with the simvastatin, and below 55 with the simvastatin and HTMI, follow for 6 years, and it did show modest reduction of some cardiovascular events, much more pronounced in diabetic population compared to the non-diabetic population. It was discussed already at length by Dr. Liu. And PCSK9 inhibitor also he discussed. This is the second drug, non-statin drug, which we know that the LDL receptors, the LDL particle get attached to LDL receptor, and by endocytes, they removed from the circulation. The PCSK9 protein gets attached to the LDL receptor and it causes their degradation. And to prevent this degradation, PCSK9 monoclonal antibodies, both injection, evolocumab has been developed, and they prevent the degradation, and more receptors are there on the surface to reduce the LDL cholesterol by almost 60%. Not only the LDL cholesterol, but also ApoB and VLDL cholesterol, and even 25 to 30% reduction of lipoprotein was observed. So there were 2 trials which have been used using the PCSK9 inhibitor. One is the chronic coronary syndrome trial, a Fourier trial, but more than 27,000 patients already on maximum doses of statin with or without HTMI. One group was given injection of evolocumab, the other one placebo. And the trial period around 2.5 years, what we found that on average, the LDL cholesterol came down to 30 milligram. And we found a 15% reduction of primary endpoint and 20% reduction of secondary endpoint, which was very important finding. But the trial was extended for another 5 years, what we say open label extension trial, and where they found the mortality benefit, which was missed in the initial trial, which is showing that the drug is very effective. Not only this, what we found that the cholesterol level baseline coming from even above 100, going down to below 200 was seen. The 60% of the patient on PCSK9 inhibitor could able to achieve LDL below 40, and 20% patient could able to achieve below 20 milligram. So and they kept on showing a reduction of cardiovascular events. With the good news that in spite of going down below 20 milligram cholesterol with PCSK9, with the statin plus minus HTMI, the drug was very safe. It did not produce any significant side effect or myalgia or neurocognitive dysfunction, new onset of diabetes, or any of those significant side effects. So well tolerated. So it found that drug is very effective and very safe. Subsequently, the Odyssey trial came in more than 18,000 patients, similar acute coronary syndrome population, this one, using evolocumab, again showing that over a period of 2 to 2.5 years, the average cholesterol level came down to below 40 milligram, and it resulted in improvement in the primary endpoint by 15%, as we saw with the Fourier trial. So both of the trials did show that the beneficial effect of the non-statin drug like PCSK9, it is very good and very safe. So what we learned then subsequently, that when we achieved less than 70 milligram, there was residual risk, and residual risk was taken care of by adding HTMI, keeping it below 55, producing further reduction of events, and then when we added Fourier or Odyssey trial, keeping it below 40 or 30, also did show a further cardiovascular events. And based on this group of studies, the ESC guidelines came up in 2019, and now the International Expert Lipid Panel, all the bodies, they all accept this is the most widely used guideline globally because of the evidence based on clinical trial. And based on this slide you have already seen, they have categorized the patients. So they've suggested that every patient with dyslipidemia comes to your clinic has to be categorized, his risk assessment should be there. Yeah, and then a very high risk population should keep it below 55, high risk below 70. I'm going into a little more detail of that. The very high risk population is the one which has got atherosclerotic cardiovascular disease, either ACS or stable CAD with revascularization, TIA, stroke, or PAD. And second important thing there which added, which we have already discussed in the morning, about the imaging technology, where we can find more than 50% two arteries block or even carotid artery showing blockage, diabetes with target organ damage, with multiple risk factors and duration of diabetic about 20 years. These were all considered along with familial hypercholesterolemia and atherosclerotic cardiovascular disease, CKD population as a very high-risk population, suggested to keep it below 55 or at least more than 55% reduction. The other secondary prevention group was the extremely high-risk population. These are the patients of atherosclerotic cardiovascular disease who experience second vascular event within 2 years, either in the same territory or in the different territory. The patient of CAD getting a peripheral vascular disease or stroke. These are those who are already on maximum tolerated doses of statin. They have suggested these are the high-risk, very high-risk, extremely high-risk population. Keep it below 40 based on the Odyssey trial. And then high-risk population, discuss single risk factor above 190, hypertension 180, 110, diabetes with risk factors, and CKD. They were suggested to keep it below 70, moderate risk 100, and very low risk as 150. Now, I will briefly discuss about our guideline, because this is based on the South Asian population. This we released recently. And in this guideline, what we found that we accepted the ESC guidelines, most of the data, because in most of the clinical trial, Indian population has participated. But here, in the regions of what we found, our prevalence data showed that whole of the country has central obesity, high triglyceride, and the low HDL cholesterol. Hypertension is present in 35%, diabetes in 11.5%, but dyslipidemia was present in our country in 82%. Mainly driven by high triglyceride and low HDL cholesterol. What we found that in extremely high-risk group population, we have added another group which we experience in our country. We are getting heart attack in younger age, less than 50%, and less than 50 years. 50% of the MI in India are below the age of 50, and 20% of them are below the age of 40, which is 3 times more than the Western world. So what we found in young MI, those who have got familial hypercholesterolemia, in our study, a large number of population of 1,200 found more than 15% of young heart attack patients have got FH. And those who have got FH, the associated elevated LPA of above 50 milligram was seen in 45% of population. Now, when we followed this group of population, they were just behaving like the recurrent coronary artery events, severity of the disease was coming. So we classified them as extremely high-risk population, suggesting to keep it below 40 or 30. The very high-risk population, we did not differ. The high-risk population, we have some additional point we found based on the HOPE-3 trial and some of the data of our country. Those patients with hypertension, with target organ damage, or hypertension with at least one of the risk factors, like tobacco, family history, central obesity, or diabetes, we should keep them just like diabetic with risk factor below 70, not 100. And for low-risk population, we suggested to keep it below 100 milligram. Now here, in our guideline, we have suggested very strongly that LDL cholesterol target should also have a non-HDL cholesterol target. There should be co-primary targets in our country because of high atherogenicity, atherogenic dyslipidemia, which we see in our country. So we have given that for 40, it should be less than 70 for extremely high and less than 85 for the very high-risk population in our country. So with this, we went into the management strategy of acute coronary syndrome in our population, suggested very strongly to have a non-fasting lipid profile estimated as soon as the patient comes to the hospital. And we decided to hit hard and hit early with high dose of statin, Rosuvastatin 40 or Atorva 80, along with ezetimibe combination to begin with in all patients, because in our own study from our country have shown those who have got LDL cholesterol baseline above 110, if you give them only high dose of statin, then chances of reaching the goal is only 60%. But if you combine then it comes to around 85% or so. And second thing, what we found in our study was that the next lipid profile should be done at 4 weeks, not at 6 weeks. Because what we found in a patient study where we did the lipid profile at age 0, 7, 14, 28, and 42, we found the peak action of the cholesterol statin comes at 4 weeks. Beyond 4 weeks, there is no further reduction of cholesterol. So with this hypothesis, and we know the ACS patients, they get recurrent events within 10 months, so with this 10% within 3 months. So we decided to hit them hard with all the 2 drugs together and wait for 4 weeks. If not reach the goal, then add bempedoic acid. If wait for another 4 weeks, not reach the goal, then add the injectable PCSK9 inhibitor. And finally, I would like to discuss that in spite of reaching that low is a number of patients in our clinical practice which we have seen. We have treated them very well with the statin or non-statin drug. Their LDL is below 55 or 40 wherever, but yet they continue to have events. And that's what we found. It was the high triglyceride, which is highly prevalent in our country, which has played a role. High LP has already been discussed, maybe discussed in subsequent talks. I will not touch that, but let me discuss about that. And we decided that any patient above 150 triglyceride should look for non-HDL as a target. Total cholesterol minus HDL, very easy to calculate. And they include VLDL, IDL, and small chylomicrons. And we have learned now, there's all these three, along with they make the size of LDL particles small in atherogenic dyslipidemia population. They all put together enhance the chances of atherosclerosis. So it's a good paper. We should look into the non-HDL cholesterol better reflect residual risk than LDL cholesterol in statin-treated patient whose LDL goals have been achieved. And we have learned now from the data recently published in JACC also that the remnant cholesterol present in the triglyceride is a very highly atherogenic. Number may be small, but it is highly atherogenic. We cannot ignore that part along with the LDL cholesterol. And in our guideline for management of triglyceridemia, we suggested that the management look at the non-HDL cholesterol, and non-HDL cholesterol can be very well managed with the lifestyle modification. But in some patients with atherosclerotic cardiovascular disease for secondary prevention, and particularly diabetic with risk factors with high triglyceride, we have suggested to give them statin or non-statin drugs, and also to add IPE, eicosapent ethyl, if the non-HDL not reach the goal of less than 130 in that patient and less than 85 for secondary prevention patients. The phenofibrates role is much less for such population whose triglycerides are less than 400 or 450. This has been already discussed by Dr. Ping Liu, just to show that clear outcome have clearly shown. So besides the non-statin drug, we have now bempedoic acid, which we have incorporated in our guideline. It reduces cardiovascular events for both primary and secondary prevention. And inclisiran, which we have just discussed, that this is a drug which is found to be very effective. Not only that it reduces 50%, but sustained reduction has been seen. And the Orion 9, 10, 11 meta-analysis have shown that a small number of patients, but did show some reduction of MACE, because we do not have the data of the Orion 4 trial and also the PREVENT trials, which are Victorian PREVENT trial, which is going on at the moment. But that this shows that the exploratory outcome are in favor. The drug has additional advantage of compliance and also the less of LDL variability. And finally, let me just briefly discuss that since our topic is the no cholesterol, no coronary artery disease, but it looks right now that if you reduce the LDL cholesterol below 50 milligram, there is less progression of atherosclerosis. The Glasgow trial using PCSK9 inhibitor and using IVUS on more than 900 patients did show there may be some regression of the atherosclerotic plaque, which has been observed in this trial. And also like to share with you that Brownwell's paper, you must have read that the cholesterol, the race to bottom, he suggested that there is a substantial evidence that now the low levels of LDL and ultra low levels of LDL are well tolerated and safe. In secondary prevention trial, these low levels might be more effective in reducing MACE than the common guideline targets now of 70 and 55 and below. It would be desirable and safe to conduct a prospective randomized trial to compare the clinical effectiveness at all the three target levels. And we should remember the 40 years ago, Dr. Brown and Dr. Goldstein, the Nobel Prize winner, they gave their lecture that they suggested that the level of 25 milligram is enough for body to nourish the cells. And their strong suggestion was that we should keep the LDL between 25 to 60 milligram. This was 40-year-old data which shows. So in conclusion, dear friends, what I want to say now, that the evidence from the clinical trials have shown that for secondary prevention of atherosclerosis, very high-risk population and extremely high-risk population, they require aggressive lowering of LDL cholesterol to reduce cardiovascular events. In patients with high triglyceride, in spite of LDL being at goal, one should target non-HDL cholesterol, because we make mistakes in clinical practice if we ignore them to address the residual risk. Intensive lipid lowering treatment, statin with non-statin drugs probably will be required. Majority of the patient for secondary prevention in clinical practice. So what Dr. Ping Liu has just said, that for secondary prevention, the dictum should be earlier the better, lower the better, longer the better. But we have added in our guideline that together the better, because most of the patient probably will be requiring statin and non-statin drug. Number two, most of the patient have to look into the LDL and non-HDL goals. Both should be looked into that. Thank you very much for kind attention.
Okay, thank you, Professor Sony's excellent talk, reviewing the role of secondary prevention in ASCVD and share the guideline from India. I found it's a very aggressive strategy in India for secondary prevention. So any question or comment from audience?
I wonder whether I could ask, that was a great talk, really. I really enjoyed that. Are you convinced that we have enough evidence to target remnants in the setting of an optimal level of LDL cholesterol with additional therapies? I mean, acknowledging that the analysis of the REDUCE-IT trial suggests that the benefit is not mediated by triglyceride-rich lipoprotein remnants.
Yeah, I think a good question. That what we've learned, that what make mistake is that we keep on looking at the triglyceride levels. I think we should not look at the number of triglyceride. We should look at the non-HDL. Because I have got many patients in my clinical practice, those who came to me and are very happy their LDL was 50 with the statin and HTMI combination. Within 6 months, they had another event. I look back to look into the lipid profile report. I found his triglyceride was 215 and his non-HDL, instead of 85, it was 104. So I thought this is probably my mistake. So I put him on, intensified the drug treatment and tried to keep non-HDL below 85, which is the target now. And after that, this patient is quite stable. So I think these are the few personal experiences. And now we have a data which I've just shared with you, the DAC paper and the paper recently published where they look into ApoB and non-HDL as a target. And they suggested the non-HDL, which includes LDL and the remnant cholesterol of the triglyceride, they have shown that it is more atherogenic, it causes more cardiovascular events. This is the best predictor of future cardiovascular events. So that's why I think, and I also like that comment which you made, that the LDL present in LPA is generally resistant to the statin treatment. So in clinical practice, we did come across that the patients, those who have got response to statin, like a resistant type of statin, instead of 50%, we found 40% reduction of LDL. We started looking into the LPA, which we were not doing routinely earlier. And we found it was very much elevated. So our own study of 1,500 patients of acute coronary syndrome, we look into the lipid and LPA. And what we found very interesting, our general population in India has LPA elevated is in 25%. In acute coronary syndrome, we found 35%. And between young and elderly, the high LPA was seen much more common in young population compared to elderly population. And thirdly, we use the Jensen score and looking at the severity of the disease in the coronaries, and we found the high LP has a linear relation to the severity of the disease. And finally, our last paper, which we published in ES, in atherosclerosis, that those who have got familial hypercholesterolemia, diagnosed by Dutch lipid clinical criteria or by genetic testing, there we found association of high LPA above 125 millimole was 45%, which is much higher than the general public. So these were the observation which made us probably we should not neglect LPA and triglyceride also. And for LPA, unfortunately, we do not have any specific treatment. We are looking for pelacarsen to get the results from Horizon trial to see whether it will be effective in reducing the LPA by 80%.
You know, I accept all of that, and I, intuitively, it looks as if remnants are important, but we don't have any evidence at the moment that if you actually treat anyone, prospective clinical trials, people treated to LDL cholesterol goals with a statin as with residual hypertriglyceridemia. I mean, residual hypertriglyceridemia, whether if we look at remnants specifically, by specific triglyceride lowering therapy, that there is benefit. Yeah, reduce it, positive, but reduce it is a smoke screen for triglyceride effect. The effect is not mediated by the changes in triglycerides and remnants, which are actually quite small, actually. So, until we do that trial, I think it's a low level of evidence, targeting remnants. And statins are very good at targeting remnants, as it happens, really. But I think trial needs to be done, and we've all presented so much evidence, but no one has presented any evidence. And you presented reduce it, really, that reduce elevated remnants decrease is therapeutically compared with placebo, decreases the incidence of cardiovascular disease over 5 to 6 years or over 4 to 5 years. That trial still needs to be done, and the $64,000 question, or I say the $65 million question, that's at least what the trial costs, if not more, is what is the agent to do, really. I mean, I think non-HDL cholesterol seems simple, but it's clouded by, as you said, really, measurement LDL, LP(a) in there. I think a trial that serves people for elevated remnants specifically is what we need in order to take that triglyceride paradigm to a different level of evidence and guideline.
Yeah, I think the reduce it trial, what I remember, the ApoB reduction was significant as against the strength trial. So that was one of the indirect methods showing the ApoB is equal to non-HDL cholesterol. Probably might have played a major role in reducing the events in the reduce it trial. At the same time, they've increased the level of EPA in this patient's level of EPA.
Yeah,
also.
I mean, the landmark analysis suggests that by far the lion's share of the benefit is mediated by the area under the EPA curve. And triglycerides makes no more than a 15% benefit. So it's remnant effect.
I think probably they did not look into non-HDL. They look into the ApoB particle. It did show a reduction significantly in those patients whose EPA level came up. The ApoB, I say it is equal to non-HDL, maybe a way of looking into that.
It's it's a bit independent. That's what the evidence suggests at the moment they presented, actually, which is difficult, actually, because there's no dose titration. What is the target? The benefit appeared to be independent baseline triglyceride level. So you give a drug and forget. There's nothing to look at, really. It's not as if the lower better the LDL. I mean, LP(a) is going to be the same thing. There's going to be probably no goal. Just one injection and goodbye. The cells are positive. And for remnants, I don't think we have the answer. There's a lot of circumstantial evidence, that you've very nicely alluded to. I think the jury's still out in the book, really.
Thank you, sir. Thank you.
Okay, thank you. So next, I will invite Dr. Walsh to introduce the next speaker.
No, you introduced Dr. Tada. I'll do the last one if you want, and then you can wrap up.
Oh, okay. So let me introduce the next speaker, Dr. Tada from Japan. Currently, Dr. Tada is a assistant professor from the Department of Cardiovascular Medicine, Graduate School of Medicine Science, Kanazawa University. Today, he will give a speech entitled Lipoprotein A in Atherosclerotic Cardiovascular Disease, Residual Cardiovascular Risk or Risk Marker Therapy. Dr. Tada, please.
Okay, so can you hear me?
Yes, very clear.
Okay, good. Okay, now, so hello, this is Dr. Tada from Kanazawa, Japan. I'd like to talk a little bit about LP(a) as a residual risk factor for ASCVD. LPD2A is a particle consisting of LDL-like particle and apolipoprotein little a. And we know very well that LDL is a causal factor for ASCVD, and that apo little a has the structure that are similar to fibrinogen, which is close-thrombotic. So it is very easy to understand that this particle is quite atherogenic. In fact, it has been shown that one LPD2A particle is about 6 times more atherogenic than one LDL particle because of several reasons, including oxidized phospholipid, pro-inflammatory protein, and small size and anti-fibrinolytic properties. However, it is important to note that humans typically have more LDL particle than LPD2A particle. And when we take a look at the distribution of LPD2A, it is highly skewed. But it is also important to note that around 20 to 30% of the population has levels above the risk threshold for ASCVD. And this figure illustrates the distribution of LPD2A among different ethnicities. And it has been shown that LPD2A levels among Africans are the highest. On the other hand, the LPD2A level among East Asians, including Japanese, are the lowest. However, there are still substantial number of individuals who have elevated LPD2A even in Japanese population. And it has been shown that individuals who have elevated LPD2A level have increased lifetime risk for ASCVD. As you can see here, there are substantial differences according to their LPD2A level strata. And more specifically, it has been shown that LPD2A levels are associated with the presence of low attenuation plaque on the left. And as a result, we can see that incidents of myocardial infarction are more frequently occurred among patients with higher LPD2A levels on the right. And more importantly, it has been shown that other risk factors, LPD2A, it was associated with myocardial infarction as well as aortic valvular stenosis that we still don't have any specific useful drugs to reduce the risk. And also, it is interesting that we can see inflammatory processes appear to be involved in development and the progression of aortic valve calcification and aortic valve stenosis. So we believe that intervention for LPD2A could reduce the risk for aortic valve stenosis. And now let's move to the story of genetics in Japanese population. Actually, we had a chance to investigate this topic using 112 Japanese patients with genotyping of LPD2A gene locus who had increased LPD level greater than 670 milligram or very low level of LPD2A less than 5 milligram. We could obtain genotypes of 187 SNPs within LPA gene locus. And we investigated the associations between these genotypes and LPD2A levels. We found that there were 6 SNPs that were significantly associated with LPA levels among Japanese. And it is very interesting to see that 3 of them were already shown that had association with LPD2A among other ethnicities, while other 3 SNPs were associated with LPD2A uniquely in Japanese. when we created polygenic risk score comprising 6 SNPs, then we could see that polygenic risk score of the individuals with elevated LP(a) were significantly higher than that of the decreased LP(a) levels. In addition, we could see significant trend that LP(a) levels in individuals with a higher polygenic risk score were higher. So we could show you that LP(a) levels appear to be determined genetically among Japanese as well, and that there are shared and unique genetic backgrounds determining LP(a) level among different ethnicities. So now let's move to the clinical guidelines in the world. Clinical guidelines in Western countries have suggested that LP(a) level should be measured at least once in a lifetime, and that LP(a) level should be measured in individuals with family history of early onset of ASCVD or other high risks listed here. However, it is quite unfortunate that there is no clear indication of LP(a) measurement in the current Japanese clinical guideline. So let me share with you the current status of the LPA testing in Japan in 2020. This is a data from National Database of Japan in 2020. We simply compare the number of testing for LDL cholesterol measurement and that for LP(a) measurement in outpatients clinic as well as inpatients clinic. We found that only 0.17% of the patients who measured LDL cholesterol also measured LP(a) in outpatients, and only 0.87% of the patients who measured LDL cholesterol also measured LP(a) in inpatients. I think it clearly suggests that awareness of LPA testing is still quite low in Japan. So now we are planning to implement 4 different strategies, including survey, statement, education, and treatment in Japan with Japan Atherosclerosis Society. What can we do now? I think one of the steps could be cascade screening of high LPA individuals, because I stated LP(a) is very highly determined by genetics. So if you encounter an individual with high LP(a), then you have a chance to identify other relatives who have elevated LP(a). How about the treatment? Well, I would like to recommend to modify lifestyle in patients with elevated LP(a). In this study, we have found that a healthy lifestyle, including non-smoking, healthy diet, avoiding obesity, and regular exercise, could mitigate the risk by an elevated LP(a) level in Japanese population as well. So currently, it could be summarized, shown in this slide. First, in the absence of specific LP(a) strategies, early traditional risk factor management is recommended for individuals with elevated LP(a), taking into account their absolute ASCVD risk and LP(a) level. And second, among patients with high LP(a), all ASCVD risk factors should be optimally addressed, especially in high-risk patients. And thirdly, lipoprotein apheresis can be considered in patients with high LP(a) and progression ASCVD. And also, we can identify a familial risk via cascade screening. And this slide also summarizes the medications for high LP(a). Now we can use PCSK9 inhibitors in our clinic, but it can only reduce it by around 25%. However, newer drugs are now under the phase 2 or phase 3 clinical trials that can reduce LDL-A level substantially. So I'd like to conclude my presentation as first, LDL is one of the most important residual risk factors for ASCVD, and LDL levels appear to be determined genetically, so it should be measured at least once in a lifetime. LDL appears to be a causal factor for ASCVD, and we need to treat more intensively the patient with high LDL-A. And also, newer agents are coming soon that can reduce LDL level substantially. Thank you very much for your attention.
Okay, thank you, Dr. Pada's comprehensive review the role lipoprotein A in ASCVD and share some preliminary data from the Japanese survey. And any comment or any suggestion from our audience?
Yeah, I'd just like to make a point about this business that the guidelines state that it should Lp(a) should only be measured once. I think this overlooks a fundamental property of Lp(a) that it is a highly variable measurement. It is not so that you're born a level, it remains at the level. Lp(a) can have a high variability. Lp(a), for instance, is lower after an infarct, and it can increase after follow-up. I think if Lp(a) is sky high, yeah, and it'll remain high, and you make a judgment. If your Lp(a) is undetectable, less than 5 to 10 or 15, 20 nanomoles per liter, you probably don't need to repeat it again. But in between, I'm using the nanomole per liter, between, say, 100 nanomoles per liter and up to 200 or so, 250, where there will be thresholds for risk stratification, and there are going to be thresholds for trials, and there are going to be thresholds for initiating treatment. Your Lp(a) could be 210, and then you measure it again, could be 180. And I think around critical thresholds, when you're going to make clinical decisions in time, that you need more than one measure. And Lp(a), changes with renal function, Lp(a) change during pregnancy, Lp(a) changes after the menopause. So the idea of measuring one, forget about, probably right if it's unpredictable, incredibly hard. But I think in Australia, it doesn't really pertain to other levels of Lp(a). I mean, the other point, everyone has said cascade testing. Well, you've got to think cascade testing means various things, but if you screen, the question is, Dr. Dada, I'm interested, what level of Lp(a) would you recommend proband that the family should be cascade tested for Lp(a)?
Okay, thank you very much for your very important and nice question. I would say the cutoff value for to determine the proband is like 30 milligram per deciliter in Japanese, because in Japanese population, I think the cutoff value should be very low in terms of the changing strategy for treatment. So at least in Japanese population, I recommend to check the cascade screening in about the patients greater than 30 milligrams per deciliter.
Yeah, I mean, we're interested in doing that. And when we use probands, families whose Lp(a) was, say, 50 nanomoles per liter, we ended up screening a lot of family members that didn't have substantially elevated levels, and we find it was cost effective. Only till we went further up and identified proband with LP(a) levels of greater than, say, 180 or 100 nanomole per liter, then you could screen the family and find, elevated levels. The family level will always be lower than the much lower than of the band on average. The difficulty is, although it's a great idea, there is a parallel with FH. Momentary, there's so many people with elevated LP(a). In Australia, for instance, in New Zealand, there's all about 6.5 million people, that if we start cascade taking probands with levels as low as 50 nanomole per liter, we won't be able to do it, actually. We've recommended, and I've published this, that actually, at least if you start, you have a program that's funded, that you actually start with very levels of LP(a) proband.
Okay, thank you for your inputs, but I believe that the testing for LP(a) is not so expensive. So that's why I recommend to set the threshold to very low level. Even though you have a not a substantial number of individuals who have a high LP(a).
But if you set it low, your chance of finding high levels are low. You'll find that it will be cost effective. Try it and see. We tried to do this out of our clinic, and it was not cost effective, so we stopped doing it. But it's some experiments that you should, at what level of LP(a) used. And at the moment, I mean, a lot of reluctance. I know that Japan has been a bit quiet about LP(a), not with good reason, because at the moment we do have evidence that if you lower LP(a), there's a benefit. It's missing link in the piece. At the moment, there's a frenzy here of testing, but the quietness of Japan has been justified. Let's get evidence first, then let's do it.
Yeah, I think, Dr. Tada, my suggestion that the earlier about 30 milligram was considered at high risk. Now we have globally all the guidelines accept more than 50 milligram as a clinically relevant, although the risk starts at 30 and above, but above 50 has been now accepted globally. And at that stage, probably doing a cascade screening of the family member may be more cost effective, this looks like. And number second, the levels, many patients of mine, they repeat their level, which is not needed. I think once it should be done only once, except the patient has got some thyroid disease, CKD, or some infection going on. Maybe in the post-menopause women, it goes up as a natural physiological mechanism. So I think the level cut up, what is accepted is now looks like 50 rather than 30 now.
Okay. I can discuss it.
No, I mean, I think we've got to talk about nanomoles per liter. The milligrams per deciliter has been, or grams per liter has now been recommended wherever possible. But I mean, cascade testing, as I said repeatedly, Professor Swami, it's only when we select people for having LP(a)s of greater than 1 gram per liter, which is 100 milligrams per deciliter, was it cost effective. But I think if your LP(a) is undetectable, you just don't measure again. Actually, it's time. If it's high, you're at high risk, and it's when you're going to make decisions about. You wait if the trial's positive, and you're drawing lines down cut-off points, say 8 milligrams per deciliter point, or if you wish, or 170 nanomoles per liter, to put people on therapies, and you're just a little bit below it, 10 nanomoles per liter below, or you'll measure it and you'll be above it, actually. So you need to do several movements. So anyway, that's a great talk, and great to see Japan coming in on LP(a), but I think it's conservative, which has a great power of logic, actually, in terms of meeting the criteria criteria for screening for something, which the most powerful one is that you need evidence, reduction of risk with intention. And at the moment, there is no grade 1 evidence. So, there is some rationale in it. So if I could just thank you, Dr. Tadar. Let's move on to the final presentation, which is from Dr. Noor Ashkin Binti Mod C, who's from Malaysia, and she's going to talk about light at the end of the tunnel for triglyceride-rich lipoproteins, and this is relative to what we were talking with Dr. Sani earlier, and reduction of ASCVD by PUFA, ApoC3 inhibitors, and PTL3 inhibitors. Dr. Sani, over to you.
Hello, good afternoon. Thank you so much. Thank you so much to Prof for the kind invitation and introduction. The topic of my talk today is TG-rich lipoprotein therapies to reduce CVD risk by polyunsaturated fatty acid, ApoC3 inhibitors, and angioprotein-like 3 inhibitor. So, sorry, there's supposed to be some writing there, but I wanted to start with, there's a review paper by Nosgard et al., where in this paper, he simply stated that TRLs or TG-rich lipoprotein simply contain TG cholesterol and also phospholipids and various proteins. He also suggested that for simplicity in practice, we can evaluate the levels of TRLs in our patient by simply doing these two measurements. First is to look into the TG content, that is by assessing the plasma TG level, or second, to look into the content of the cholesterol by assessing the remnant cholesterol, which is what they do by measurement with total cholesterol minus HDL and minus LDL. And this is an illustration from the ESC consensus statement, simply to show that how TRLs include all the newly synthesized VLDL, chylomicron, and all their remnants before they end up being metabolized into LDL or being cleared by liver or when they penetrate the artery wall. TRLs in many studies has been shown, high TG has been shown in many studies to be an independent risk for CV events. But one of the more important studies or results come from PUFA study, which is in the cohort of secondary prevention in a cohort of patients after MI, where it was shown that how even after LDL has been optimized into less than 70 mg per deciliter, those patients with TG above 200 mg per deciliter still would have associated 40% greater risk of MACE compared to patients with TG level of less than 200 mg per deciliter. Remnant cholesterol also has been shown to correlate strongly with CVD in a study by Castaner et al., where they wanted to see the association of TG and remnant cholesterol with major adverse cardiac event in a cohort with high CV risk. So the result shows that both the level and the TG level and remnant cholesterol were independent predictors of major adverse cardiac event. So even though high TG can be a marker of high cholesterol content in TRLs, but the ratio of cholesterol to TG content in TRL varies significantly. Unlike cholesterol, TG can be degraded into fatty acids by most cells, and TG also does not accumulate in atherosclerotic plaque. And unlike the huge chylomicrons, the remnants VLDL, IDL can cross endothelial barrier, enters into intima, and cause atherosclerosis. Therefore, it is appropriate to also measure the cholesterol content of TRLs, that is to measure the remnant cholesterol, than to solely measure the TG level only. Now we look into few therapies that has been investigated in clinical trials for patients with high TG and high TRLs. In 1999, results from the GC prevention trials have shown benefits in patients with high TG and recent myocardial infarction, but only a low percentage of those patients were on a background statin therapy. Multiple large studies has been conducted since to examine the benefits of EPA and DHA, the types of polyunsaturated fatty acids, which have failed to show consistent results in reducing CV endpoints. So this is from a recent review on the clinical trials of omega-3 fatty acids. So if you look at it, there's only two studies that have shown positive results, which are the JELIS and the REDUCE study. And both of the study has used only APA formulation as the study product. JELIS is a Japan APA lipid intervention, open label, blinded endpoint, which has recruited more than 18,000 Japanese with high cholesterol. So they compared APA daily plus a low intensity statin versus statin alone, with a mean follow-up of 4.6 years. The primary endpoint of MACE was reduced about 19% in the APA group compared with control, 9% reduction in TG, and no different in LDL levels. So the trial had a prospective blinded endpoint design, but with no placebo. There were concerns about it not being a more rigorous double-blind placebo control trials. APA was tested in comparison to usual care in patients who were mainly on low-intensity statin therapy only. Next is REDUCE. So it's quite recently published in 2019. It's a randomized control trial for CV outcomes. They had more than 8,000 patients with high TG, established CVD with DM or other risk factor. So the patient were on guideline-directed statin with a baseline fasting TG 1.52 to 5 millimole. Median LDL were 1.9 millimole per liter. They receive IPE, icosapent ethyl, or the placebo were in the form of mineral oil. So the primary endpoint was improved in a patient on IPE, where they was reduced hazard ratio of 0.75 versus the placebo, and also positive result in terms of reduced hazard ratio in a patient on CV death in a patient on IPE. However, there was significant hospitalization for AF recorded in IPE group. There were also more serious bleeding events in IPE group. Patient in placebo group, which was the mineral oil, had higher LDL levels, ApoB, and also CRP level versus basis during the baseline. The subgroup analysis showed lower risk of adverse outcome, irrespective of the attained TG level at 1 year. So a year after the STRENGTH study, the REDUCE-IT study, another study on omega-3 fatty acid was published the following year. So it's a STRENGTH study, another randomized control trial for severe outcome. They had more than 13,000 patients with high TG, again, quite similar cohort with established CVD or with CV risk factor. Again, they were on high intensity statin, baseline TG between 2 to 5.6, median LDL also similar, about 1.9 millimole per liter. They received 4 grams of EPA combined with DHA and versus placebo in the form of corn oil. So this study were terminated early because at the interim analysis, it has showed low probability of clinical benefit. The primary endpoint was 12% versus 12.2% in placebo, but they also recorded higher number of AF in the patient on the study product. Now we move into another new therapy that's been investigated, which is the apolipoprotein C3 inhibitor. ApoC3 is a component of remnant particles. It is associated with high TG and also high remnant cholesterol. It is an endogenous inhibitor of lipoprotein lipase and also hepatic lipase. Those are enzymes that involve in hydrolysis and clearance of TG and TRLs from the circulation. ApoC3 increases plasma TG by inhibiting hydrolysis of TRLs by lipoprotein lipase and also by attenuating uptake of TRLs by the liver. So this is an interesting study that was performed by a Danish group in a Danish population. It was done to evaluate the association of TG and MACE and also the loss of function mutation of ApoC3 with TG and MACE. They had recruited more than 75,000 participants and their median follow-up was about 34 years and they had 100% DNA data available. So in the results, they found that how patients that had or how the subject with a TG less than 1 millimole had much lower CVD rates as compared to participants with high TG more than 4 millimole per liter. And they also found how heterozygosity for loss of function mutation in ApoC3 had lower TG versus patients or participants with no mutation. This heterozygosity group also had recorded a lower CVD with hazard ratio of 0.59. So olezarsen is the newer drugs for that target ApoC3 is a third generation antisense oligonucleotide. It selectively binds ApoC3 messenger RNA, preventing its translation, resulting in reduced plasma ApoC3 and also TG level. It is conjugated with GalNAc, therefore it enhances its targeted delivery to hepatocyte. This GalNAc conjugation with its enhanced targeted delivery to hepatocyte should result in smaller doses requirement of olezarsen, should lead to longer duration of action and fewer side effects as compared to its predecessor, such as volanesorsen. So this year, olezarsen has got 2 recently published results of their trials. The first one is a trial Bridge-TIMI 73. It was a phase 2b randomized control trials to evaluate safety and efficacy of patients with moderate hyper-TG and elevated CV risk or patients with severely high TG. The primary outcome were to see the change in their TG level from baseline to at 6 months. And also the secondary outcomes were to look at the changes in the levels of ApoC3, ApoB, HDL, and LDL. So they had about 154 patients randomized. The patient median TG was more than 240. 31 patients in the study had their TG of severe levels, which is more than 500 mg per deciliter. So the 50 mg and 80 mg doses of ellazesendt reduced TG 49.3% and 53.1% respectively versus placebo. Each dose of the ellazesendt reduced ApoC3, ApoB, and non-HDL significantly, but there were no significant changes in the LDL level. So the clinically meaningful hepatic, renal, or platelet abnormalities were uncommon and with similar risks in each group. The second study that was also published this year regarding the ellazesendt drug is the BALANCE trial. It's a phase 3 double-blind placebo-controlled trials among patients with familial chylomicronemia syndrome. They receive ellazesendt at the dose 80 or 50 mg or placebo every week for 49 weeks. The endpoints were fasting TG level from baseline to 6 months, and also to see the incidence of acute pancreatitis. So the patient, they had 66 patients. The mean TG was more than 2,000 mg per deciliter, and 71% of patients recruited in the study had previous history of acute pancreatitis over the past 10 years. So TG levels at 6 months were significantly reduced with an 80 mg dose versus placebo. They had reduction about 43.5%, but not with a 50 mg dose. So 11 episodes of acute pancreatitis were recorded in the placebo group, but only 1 episode of acute pancreatitis occurred in each ellazesendt group. Angiopoietin 3-like inhibitor. So angiopoietin-like 3 inhibit LPL and also endothelial lipase. Angiopoietin 3-like inhibition results in increased remodeling of the TRLs into smaller remnant particles, which are more efficiently cleared by the liver. In addition, the increased endothelial lipase activity may also lead to enhanced TRL clearance upstream to LDL production and also decrease in endogenous VLDL production. So this is an illustration just to show as to how the angiopoietin 3 inhibitor enhance EL-dependent remnant clearance upstream, improve the remnant clearance upstream to the LDL production. So vopanosine is one of the GalNAc conjugated antisense oligonucleotide targeting angiopoietin 3 mRNA. So it inhibiting angiopoietin 3 protein synthesis. In a 6-month double-blind placebo-controlled trials, in 105 patients, the TG patient that treated with vopanosine has shown significant reduction in the TG concentration, up to 53% reduction compared to placebo. However, in the following phase 2b study on about 200-something patients with moderate high TG on statin, there were modest reduction of TG, but there was significant increase in hepatic fat fraction investigated using MRI, and the higher doses of vopanosine also associated with more than 3 times elevation of liver enzyme. Therefore, the development program for these drugs was discontinued. Regarding angiopoietin-3-like inhibition to treat severe hyper-TG, actually there's another new drug under development after the cancellation of the bupanosine program. It is a small interfering RNA targeting angiopoietin-3 or ARO angiopoietin-3. Unlike the ASO, which acts in the nucleus of hepatocyte, the small RNA acts mainly in the cytoplasm, and the phase 2 trials on the ARO angiopoietin-3 inhibitor are currently ongoing. Thank you.
Thank you very much for that presentation. That's very good, and it brings to mind exactly the discussions of what need to be done. But just from point of view for information, the NHP3 into trial with dasiran was published in the New England Journal of Medicine in May, and the RNA with dasiran was also published in the same May article in New England. In extent that with the APO3, that's proceeding to clinical endpoint trials. Also, the APO3 RNA with quarterly dosing, that's also a significant reduction in acute pancreatitis, and here in the new within the next course presented at the ESC. Just by a bit of information, we need to update those files for next presentation. So open up for discussion. There is time. We do have times for discussion. And one may ask our colleague whether these trials are going to answer the question that we were discussing earlier concerning the management of remnants. Can I ask you, Dr. Hari, what was your assessment of the contribution of triglyceride-rich protein remnants to the benefit of on cardiovascular events in MACE, the fibrate MACE in the REDUCE trial?
Sorry, Prof. So you wanted to ask...
What was your assessment? When you actually read the literature, what contribution did you agree, or do you see any data that led to believe that there was more evidence for a triglyceride reduction rather than a pleiotropic effect, the effects of icosapentae on point MACE in reducing?
What I gather from the reading of that paper, and also based on discussion that I saw regarding the trials, Prof, it mainly, they acknowledge the benefit of IPE for the CV reduction, but that's why I think it's already incorporated in many guidelines for the management of patients with high TG. But they were also basically discussion that perhaps the benefit is not exactly from lowering the TG level per se, but the more mechanism involved that's unique to IPE that leading to the CV risk improvement. Because like when they discussed that how the benefit were maintained, even though the levels of the TG in the following year of assessment were quite similar between the IPE group versus the mineral oil. And also they more highlight on about how the placebo group had higher levels of what we know risk factor for CV disease, such as the LDL, as well as the ApoB, and even the CRP level.
Thank you. Thank you. Other questions? Dr. Sari?
I just wanted to, because earlier I noticed Prof asked about the levels of LDL in the more contemporary study of the ApoC3, for example. But what I noticed that when they discuss about these newer trials, including the ApoC3 inhibitor or the angiopoietin 3-like protein, and they discuss that when they say that the LDL level is optimized, they mainly maintained or agreed at the level about 1.8. So none of the study that I came across put the level of LDL at more the level of the contemporary LDL target of 1.4. But having said that, more of these trials involving the ApoC3 inhibitor and also the angiopoietin 3-like still focusing on a group with simply high TG rather than a group specifically to reduce the major adverse cardiac event or the secondary prevention, for example.
Yeah, I mean, that's a very good point. I mean, if you look at the REDUCE-IT trial, the mean LDL cholesterol was 1.9 millimoles per liter. So 50% of the people really there were above, recommended goal. And you could ask the question, well, what would have been the results if everyone was treated, to goal? So the other thing to think about in managing patients is to compare these trials on triglyceride reductions, and they are going to go ahead. I mean, olezarsen, there's going to be an angiographic study. If that's positive, they're going to go to a clinical endpoint trial. With plozasiran, with Arrowhead, they're going straight into a clinical endpoint trial that's been designed. But we have evidence really in secondary prevention post myocardial infarction that overweight obese people, most of whom have hypertriglyceridemia, have a significant reduction in second events, and quite quickly, with 9 kilograms weight loss with a GLP-1 receptor agonist, semaglutide, 2.4 milligrams daily, 9 kilogram weight loss, again by a mechanism that involves reductions in blood pressure, reductions in triglyceride, reductions in CRP. And again, the analysis suggesting that it's in part related by that, but also by a pleiotropic effect. I'm just interested, I know this is a lipid discussion really, but obesity is a lipid problem. What, members of the panel think about, whether one should be treating patients with a specific triglyceride lowering agent, and these are post-ACS patients, or one should actually go for a GLP-1 receptor agonist where you get, a 9 kilogram weight loss and a reduction in triglycerides. Any thoughts on that from members of the panel? I wonder what Dr. Sawhney thinks about that in India, where there are a lot of people with central obesity.
I think a good point what you raised, that we have been partnered to these select trials, STEP-HF trial and all that. And then we have learned that if you reduce weight by more than 10%, going up to 20%, not only there is a reduction in the triglyceride, HDL goes up, LDL also goes down, blood pressure comes down, sugar improves. So all the metabolic factors we have seen that improves. And certainly, I think that it is a very good point which you raised, that GLP-1 analog, maybe the future drugs, which will be working at metabolic liver as a whole. And they have shown clearly in the SELECT trial that this is one of the most important drug at the moment as an anti-obesity drug, which has reduced the cardiovascular event in patient, those who are not diabetic. I mean, that patient with suffering from atherosclerotic cardiovascular disease and obesity. So I think this is the future. Probably looks like it should be that we should act on as a whole all the metabolic problem which we see in a given patient, which is very highly prevalent. Globally, it is increasing, and our country, South Asia, also has a lot of patients which is now going towards more obesity, starting from childhood to the adulthood. The number is growing very well. The triglyceride part, but I personally feel that if you look at the triglyceride molecule, 60% of that is the pure triglyceride, which has no role in atherosclerosis. the rest of the component, which is 35-40%, which is the VLDL cholesterol, probably plays a role in atherosclerosis. So when the triglyceride levels are very high in thousands, 800, 1,000, 2,000, like that, probably they contain more of the ApoB large particle, which plugs the pancreatic microvascule, causing pancreatitis as a third important cause after the alcohol and gallstones. And in that, probably the management of those high level of triglyceride is to prevent pancreatitis. But the levels which are below 450 or 400, probably they have small ApoB48. They are more atherogenic. And here is the prevention of atherosclerosis. So I think what the question, which a very valid question you raised about the REDUCE-IT trial, probably in my view, probably the IPE, what levels which increased, has been protective as an anti-inflammatory drug, which has played a very important role. And when we have added DHA to EPA, the benefits were not there because DHA is a pro-inflammatory component of the fish oil. So I think you have a very point that the total number of triglycerides did not reduce. I think it is immaterial. The drug acts by different mechanism. To me, it looks like by anti-inflammatory mechanism, by increasing the IPE level, by reducing ApoB particles, which probably to me indirectly looks like non-HDL particle. So that's probably the difference between the two group of high TG population, less than 500 and above 500 group. Probably they are different, and management strategy probably needs a little different approach.
Yeah, thanks very much. Just one point just for the group that, we said are not worth measuring triglycerides, but you've just raised the point that we got to measure triglycerides to see who has a triglyceride above 10 mLs, 10 mLs per liter, more than 1,000 milligrams per deciliter, because of the risk of pancreatitis. It's about 3% of the population, but that's significant. Other thing is, I don't really believe that the triglyceride story has been put to bed, really. There was papers in GI recently, experimental animals, actually questioning whether just the cholesterol, triglyceride-rich proteins, they demonstrated that lipid particles in animals that lacked adipose triglyceride lipase activity, that if you accumulate lipid particles like you accumulate lipid particles in the liver, that set off inflammation and set off oxidative stress. So, the suggestion is that here is a new mechanism that triglyceride particles taken up by epithelial cells cause a kind of subendothelial steatosis that sets off inflammation. Not to say the cholesterol is not important, but I mean, it's been put around the triglyceride has nothing to do with cardiovascular disease, but the study in JCI actually questioned that. Now, it's been a great discussion, great presentation. I now hand to Professor Lin to summarize and end the meeting. Professor Lin.
Okay. Watts, please proceed to the closing, please. So, okay. Thank you about all panels participate this wonderful meeting. I think all the 6 speech we learn more from all 6 speech, and we can use the knowledge we get today to our daily practice. And also finally saying thanks for the APSC Cloud committee to organize this symposium, especially Professor Jun Lin. He is also online. Thank you for your organize this symposium. So if no one have a further question or comment, I think I should close this symposium. Thank you all your participation again. See you in the near future.
Sure.
Thank you.
Thank you very much.
Thank you.
Ciao.
Bye-bye.
Bye-bye.
Bye bye.
Bye-bye.
Thank you. Thank you. Bye bye.
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 Yeah.
Bye-bye.
Bye.